In an IVF cycle, IVF stands for in vitro fertilization and embryo transfer. The IVF cycle, we start with pituitary hormones in most cases. So it's pure brain FSH, follicle stimulating hormone. Follicle stimulating hormone from the pituitary gland stimulates these follicles to grow. The follicles then, several of them start to grow at once, and we'll do several ultrasounds, 3 or 4 or 5 throughout that IVF cycle in order to fully mature the follicle to the point where we can go in and retrieve eggs. We'll also typically put you on another medication to prevent you from ovulating before I have a chance to retrieve the eggs. Once the follicles have reached their developmental stage, then we'll have you take a trigger shot at a specified time. And we'll say take that at 10 at night or 1 or 2 in the morning or a specific time, and then we'll give you a specific time and day to return, typically 36 or 37 hours later, for the egg retrieval. When you arrive for the egg retrieval, we'll have an anesthesiologist or nurse anesthetist give you an IV sedation, oxygen mask, so you're completely asleep. Then we'll clean off the vagina and cervix with some medias, and under ultrasound guidance, we'll slide the ultrasound needle biopsy guide, and the needle will then go through the vaginal wall directly into the ovary. And we'll drain all the follicles from that side. Illustrated, the fluid and the eggs go down in the test tubes. We hand those to the embryologist. He'll review them under the microscope and let us know how many were collected. Then I'll go into the other vaginal wall, into the other ovary, and drain them from that side as well. Afterwards, you'll just rest, recover, go on an antibiotic, take it easy. Bed or just rest that day. The next day, gradually build up to activity according to how you're feeling. Now, the risks involved nationwide and worldwide, for that matter, doing in vitro. Basically, anytime you're on birth control pills beforehand or high-dose hormones, high-dose FSH and high hormones, are doing a surgery or are pregnant, there's the risk of blood clots or pulmonary emboli. Those are clots getting up into the lungs. Those are rare, but if you have a strong personal or family history under the age of 40 of clots, heart attacks, strokes, then we recommend you go on a blood thinner for that cycle. Other risks, it's a needle, it's a procedure. That needle, for the most part, we see 2-dimensional ultrasound. There's a 3rd dimension, though, that you can't see. So it's possible to inadvertently get into blood vessels, bowel, bladder, any of those. If we did, typically it would be a small puncture site and it would heal itself up without any problems or complications. Rarely but possible, it could form an abscess or a hematoma, which is blood bleeding inside, or infection inside, where we would have to have a surgeon go in and take care of it surgically. And in over thousands of procedures, never had to do that for IVF cycles, but it's always possible. The other risk involved is ovarian hyperstimulation syndrome. What happens is if your hormone levels go up very high and you have 15, 20, 30, 40, 50 follicles and eggs that are developing, you can imagine all those balloons of fluid in the ovaries. They're quite large to begin with. We go in and drain them and they shrink down. About 6 to 10 days later, they build back up as cysts to support a pregnancy. But instead of one, you have all those you started with. If you started developing 20 of them or 30 or 40 or 50, you can imagine that as they grow back up, these ovaries are going to be quite large with cysts. The small ones, from not developing fully, they can grow 5, 6, or 7 times their size, and you can end up with ovaries the size of grapefruits with cysts, very sore and uncomfortable. Rarely but possible, the whole ovary could rotate on its blood supply. You could lose an ovary if you didn't call us, let us know that you were in severe pain on one side. That would be the tip-off to go in with ultrasound, take a look, make sure there's good blood flow to it. That's called ovarian torsion if that were to happen. So it needs to be surgically unrotated to prevent that. The other risk is ovarian hyperstimulation syndrome. It might be minimal or mild, where you have enlarged ovaries with all these follicles or all these cysts, and it's sore and uncomfortable, but you're fine. You go on electrolyte fluids, make sure you're eating plenty of protein, take it easy. If it gets to moderate or severe, hyperstimulation syndrome, then you may start filling up with clear fluid in your abdomen or pelvic cavity or lungs, and look, 5 months pregnant, all of a sudden it's clear fluid. Because these ovaries start acting, they're very vascular at that time, and they start acting like kidney filters. So you third space the fluid and start to fill up with clear fluid in there. What do we do for that? Well, you can come to the office and we'll go ultrasound, under ultrasound guidance similar to the egg retrieval, but then we'll go through the peritoneal wall and just with the needle and drain the fluid for your comfort. Maybe once, twice, 3 times, whatever it takes if the fluid rebuilds. Or you can go to the hospital, they'll do abdominal ultrasound, and with a needle, they'll put the needle through the abdominal wall and drain the fluid there for your comfort. Rarely are people nowadays hospitalized. There's a lot of newer medications now that we use that help prevent this significantly. Years ago, 20% of all IVFs would end up hyperstimulated, going through hyperstimulation syndrome, and about 8% would have moderate to severe hyperstimulation syndrome. But nowadays, it's like less than 0.5%.